Okay, thank you. So, again, I'm Nancy Marks Erickson, along with Sharon and Laura, and with the Women with IBM. Thank you and welcome. And welcome to myositis and heart disease. We are honored today um, to have the professor of medicine, chief of the Division of Rheumatology at UCLA. Dr. Christina Charles-Schoeman. Some of you may remember her from last year's meeting in San Diego, and we're fortunate to be able to have her in here on screen. So Dr. Charles-Schoeman specializes in the care of patients with rheumatoid arthritis and inflammatory myositis. She treats patients with an aggressive she treats patients with aggressive systemic diseases, including interstitial lung disease. Um, he leads several clinical trials of novel therapies for myositis patients at UCLA. Her research interests include the study of accelerated vascular disease and inflammatory, excuse me, include the study of accelerated vascular disease and inflammatory lipoproteins as targets for disease treatment. So with that, Dr. Charles Schoeman, I'd like to turn it over to you.
Hi, everybody. Let me see if I can share my slides. All right.
Here we go.
Can you see the slideshow?
Yes.
Yes.
Okay, well, hi, everybody. I'm Christina. I couldn't be more thrilled to be with you today and really appreciate the invitation to talk about something that I've been interested in for a very long time. So I'm going to go through the talk. I will tell you how it's structured. The first half, maybe a little bit less, is going to be a bit of a recap of myositis and some of what I presented at the San Diego meeting. And that's because I think some of the concepts are there that there isn't enough data to really quite understand yet in IBM, but there should be. And then the second half, we'll get into my deep dive into what data we do have in IBM and the heart. So let's get into it. I retitled cardiovascular disease. Disclosures here, as always. But the cardiovascular system includes the heart, but it also includes vessels, which are very important when we're talking about heart disease, right? So the arteries in the red here, the veins in the blue, the superior and inferior vena cava and the aorta, and then the vessels that are in the heart muscle itself. So we're going to talk about everything. Again, overview, we'll start with the overall involvement of the heart, the arteries, and the veins, approach to risk assessment, management of disease, and then we'll get into, really in the second half, what about specific data in IBM? Okay, so we all know the heart is a muscle, so it makes sense that you have to consider involvement of this muscle when you're thinking about myositis. And this is not just in inflammatory myositis, right? In muscular dystrophies, there are papers looking at the heart and fatty replacement of tissue in the heart muscle, as occurs in other parts in the skeletal muscle. So in myositis, what has been reported is inflammation of the muscle, myocarditis, that's termed, and then other patterns of damage to the muscle. And that is, less well figured out in terms of how it gets there. But what we see is actual damage, fibrosis of the heart muscle. Just as if you cut your hand or you cut your arm, you fibrose there and you get a scar. And unfortunately, the scar in that heart muscle can then interrupt the circuitry of the heart and lead to these arrhythmias that many patients with myositis, and it's very interesting, the data suggests, when I say myositis, I'm talking about idiopathic inflammatory myopathy, so including DM, PM, and IBM. We'll get into the IBM specifically in the latter half, but you see arrhythmias in patients with myositis early in disease when there's a lot of inflammation and later in the disease. And I think that's getting into this damage, which can also lead to the arrhythmias. Of course, if you damage, you have scar in the heart muscle, you can get heart failure because the muscle of the heart is not able to contract because of that damage there, and it can't contract normally. Okay, so the question we asked many years ago, and again, is a conceptual overview because I think we need more data in IBM, but is the disease process in the heart muscle the same as in the skeletal muscle, in the legs, in other areas? So we have to first take a minute and look at skeletal muscle pathology in myositis or the idiopathic inflammatory myopathies. In both polymyositis, which now is going to be a term that I think is phased out and is getting to be much more specific in how we describe polymyositis, another time, another talk, and inclusion body myositis, you see inflammation, right, in and around these non-necrotic muscle fibers. Of course, in IBM, you're also looking for the inclusions, you're looking for these rimmed vacuoles, which are only present in a relatively small percentage of patients, right, at least on their initial biopsy. Autoimmune necrotizing myopathy is a different group. You see a lot of necrosis and minimal inflammation. And then dermatomyositis, which is going to be our case to look at in terms of answering this question, you see perivascular atrophy, okay? I'm going to tell you what that is, and perivascular inflammation. Okay, so this is a Gamori trichrome stain from a patient of mine with dermatomyositis. I told you perivascular atrophy, that's what we're looking for. It's skeletal muscle, it's from the leg. Okay, so here is a fascicle. I hope you can see my mouse. Here in the yellow, you see these muscle fibers. I want you to look at the size of these, right? Now I want you to look at the size of these muscle fibers in the center of the fascicle, right? Look how big these are. At the edge here, which is the perivascular area, they're atrophied, right? They're smaller than these. That is what we're looking for when we look at a muscle biopsy from DM. We're looking for perivascular atrophy. It's felt to be due to watershed ischemia, the involvement of the blood vessels, okay? This is a painting. It's in my home. I love this painting. It was painted by Tony Verity, who I worked with for years, a world famous muscle pathologist and just a lovely guy who, you know, I think it's very important when you think about your muscle biopsy of who's reading it and the report and what they're saying, because there's such variation in what is reported in muscle biopsies. And I think 100 years from now, when we have true precision medicine, it's going to be defined very differently. There are specifics to each individual and sequencing that can be done and so forth. And we're just really at the cusp of where I think we need to be to define everybody's disease, whether you have IBM, whether you have DM, right? That's a side point. But Tony and I spent a lot of time looking at muscle biopsies. This is some data from what we found in dermatomyositis, and it's a stain called alkaline phosphatase. We're not going to get into that because we want to get moving forward, but this is normal muscle in panel A, and the black is just a couple of capillaries that are lighting up for this alk phos. And then in panel B, dermatomyositis, and you see all these activated capillaries, right? We looked at another stain called NADHTR. Again, here's this little purple guy. This is a capillary there, normal, the stain will light up. But here in panel B, DM, look at all these black dots, right? Abnormal capillary activation. Okay, so again, getting back to our question, in myositis, can the disease process in the heart be the same as the skeletal muscle? Well, to date, so far I've shown you the skeletal muscle. What about the heart? So several years again, and I searched high and low to find this in IBM, and I couldn't find a case, and I probably know why, but I'm going to share the concept with you because I think there's more to be done in IBM. This is a case, a 36-year-old who I met several years ago, who came to us after a classic presentation of dermatomyositis. Nicest guy in the world. He just was not treated aggressively enough initially, in my opinion. He got some steroids, he got some methotrexate, they started tapering the steroids, and he went on to not only have profound muscle weakness, but to have cardiac involvement. So that by the time that I saw him, His ejection fraction was less than 20 for his heart function. And as you know, it should be more around 60, right? This is his skeletal muscle biopsy from his leg, and it's not as pretty as my first picture with the blue, but here you can see these big fat muscle fibers in the center of the fascicle, and again, look at these tiny ones, right? So he had classic perifascicular atrophy consistent with dermatomyositis in his skeletal muscle. Well, at UCLA, well, we'll get to the next part. I'm jumping ahead. Also, like I was showing you with those vessels, these are a bunch of lymphocytes right around those blood vessels. So the blood vessels are attacked, dermatomyositis. We see it here in his skeletal muscle. Couldn't be more classic. Okay, this is an ALK Phos stain, diffusely lighting up his muscle. Again, very aggressive, very active disease. So that's just a contrast with the normal muscle. Okay, the last stain, I know you guys are going to be pathologists after this lecture. Again, this outline right here, this is his muscle. This brown stuff shouldn't be there, right? That's something called MAC, membrane attack complex. It's a process of activating the immune system's attacking these vessels, and it shouldn't be there, and it's brown, right? In contrast to normal muscle. Okay, so UCLA, we do heart transplants. He comes to us, he has horrible heart failure. We don't say that's too bad. We say, okay, let's get you a new heart. You're 36 years old, right? That's what we do. And our team knew this guy, and we knew him very well. He's a tall guy, and he had to wait a very long time. I lost a lot of sleep worrying about him and working with the cardiology team. But after a few months, and when I say he's a very tall guy, you got to fit the heart to the person, right? You got to wait for the right donor. So we did, and he got his heart transplant. And our pathologist who worked with Tony Verity went in at 3 in the morning. And she went in at 3 in the morning because you have to get that heart muscle to prep it exactly like you do for the skeletal muscle, right? When you get a muscle biopsy, one of the biggest things that has to be done is that muscle has to be prepped right away, right? It can't sit, it can't wait for 6 hours. It has to be prepped right away to get an accurate biopsy report, right? So that's what Nagar did. She went in, she got the muscle. And what I'm showing you here is his heart muscle. And at the edge of this heart muscle here in the periphery, you can see here, they're bigger fibers. And here, they're getting small. He's showing changes very reminiscent of the changes in his skeletal muscle, okay? This is his ALK Phos stain. Again, it's lighting up, and look at this arrow. It's going right to a vessel there, and his vessels are lighting up with the ALK Phos, just like in his skeletal muscle. Again, this is his heart. Never had been done before, where somebody prepped a heart muscle the way they prep the skeletal muscle. And again, that MAC that I showed you, the immune complex, look at those vessels that are lighting up here in the brown, right? Okay, so parallels here, I'm not going to go over, but we found similar, I just said them, we found similar findings in the skeletal muscle and in the heart muscle again. So is the disease process in the heart muscle the same as in the skeletal muscle? Probably. If you look at this, there's no more data that I can find. And what about IBM? The answer, and we'll get into the data in IBM shortly, but I don't think we know because I couldn't find any hearts that had been prepped after being taken out at 3 in the morning, right? Thankfully, good. But I think the concept we have to think about. Okay. Moving on to arteries and veins. Very important. It is well accepted in idiopathic inflammatory myopathies. And after digging in, most of this work is DM and PM, right? But it's well accepted that there is accelerated atherosclerosis. And the studies I will tell you in DM and PM are just much bigger than what's there in IBM. We'll get into that too. Coronary artery disease, myocardial infarction, heart failure, and cerebral vascular disease, stroke. These are increased in patients with myositis. Traditional risk factors, we know about these things, right? Smoking, hypercholesterolemia, diabetes, hypertension. There's a question that someone asked about family history, obesity, and age. Some of these are modifiable, right? And that's very important in approaching risk for accelerated atherosclerosis. It's not always easy, but modifiable. So the first takeaway point for this talk is, and many of you are already doing this, so I'm preaching to the choir, talk to whoever is listening to you and who cares about you. That could be your rheumatologist, your neurologist, your primary care provider, about management of these risk factors. Very, very important. And we'll get into medications, we'll get into statins. A couple of atypical factors, and I couldn't help myself because I'm a researcher in the lab, and I think there's more to what we know about accelerated vascular disease. Inflammation systemically, one of you asked a question about this, we'll get into that. HDL dysfunction, something that our lab has been looking at. We just published a paper showing that the assessment of HDL function actually predicted who had a heart attack and who had a stroke in patients with rheumatoid arthritis. Huge database. It predicted it better than the cholesterol levels themselves, right? The function. And then interstitial lung disease, something that I couldn't find much on in IBM, but is an active area of study, which is very interesting. Okay, so inflammation, there's no doubt. This is data published 20 years ago, and it's a guideline from the American Heart Association that there is an increased cardiovascular risk based on the high sensitivity CRP level, right? And if you're less than 1, you have low risk. 1 to 3, average risk. Greater than 3, high risk. And there's a lot of mechanisms downstream from that, but that data is there, been there. High density lipoproteins. So HDL is the carrier of the so-called good cholesterol. What we do in the lab is we don't measure how much cholesterol it's carrying around. We measure how it's functioning, right? It's a particle that contains 70 different proteins. It's a very active particle that goes around and cleans up inflammation in the blood vessels. It normally protects those blood vessels. But if you have acute, if you have chronic, whether you have inflammation from an infection, whether you have inflammation for rheumatoid arthritis, whether you have inflammation for myositis that I'll show you, it can become dysfunctional. So this green particle is normal, it's anti-inflammatory. Active inflammation accumulates different phospholipids and fatty acids, and it becomes dysfunctional. And that's what we've been working on because this is a potentially modifiable particle, hasn't quite got the therapeutic yet. Okay, this is just some data. DM patients, PM patients, and IBM patients here in the top panel. This is looking at the HDL inflammatory index on the y-axis. So how inflammatory is your HDL? So higher is worse, right? It's causing more inflammation rather than protecting against inflammation. And as you can see in all of the myopathies, there's more dysfunctional HDL. That index is higher compared to healthy controls. This is another enzyme called myeloperoxidase. It's accessory enzyme, and it contributes to this HDL dysfunction. I'm going to push on because I want to get into the IBM next. This is just some grouping we did of the HDL function by autoantibody subgroups in DM and PM. Patients who have the anti-synthetase, the MDA5s, those lung-associated antibodies, again, an important area of study for IBM that hasn't been looked at yet. They had the highest HDL inflammatory index, so higher than if you didn't have an autoantibody. Okay. And then last, PON1 is an enzyme, and I mentioned it earlier, some work we published recently showing that it actually was predictive of who had a heart attack, who had a stroke in a very large RA study after we controlled for cholesterol levels, after we controlled for disease activity. This enzyme, actually the level in the blood predicted it. And what we saw here, it's supposed to be protected, but it's suppressed in patients with DM and PM. And they were pretty significant numbers, nearly 170 myositis patients and 112 controls. Okay, so we published a bunch of this work. The punchline, the takeaway is this HDL dysfunction is another potential risk factor for atherosclerosis. ILD, again, I've been mentioning this. Is it a risk factor for heart disease? No data in myositis, but beautiful data with large numbers here. Let me tell you, the numbers here were over 11,000 ILD patients and 56,000 unexposed controls. So again, we're going to compare and contrast to some of the data I'm going to get to next in terms of numbers. So this is over 11,000 ILD patients, 56,000 controls. And what you can see here in the top panel of A is ischemic heart disease, and the bottom panel of B is MI, myocardial infarction. And whether you're a male or a female, they break it down into pulmonary sarcoidosis, which is a type of ILD, and pulmonary fibrosis, which is the PS and the PF. And then they put them all together in ILD, males and females, right? So if you just look here, and let's be simple and look at ILD, the ratio here, the hazard ratio is greater than 1. So if you have ILD, whether you're male or female, you have a higher risk of having heart disease. Same thing, and that's ischemic heart disease, includes angina, includes coronary disease picked up other ways. This is MI, meaning having an actual event, same thing. Whether you're a male or a female, if you have ILD, higher risk. Okay, what about other vascular involvement? VTE, I couldn't find anything in IBM. These are deep venous thrombosis, so a clot in the veins of your legs, or pulmonary embolism. That's when that clot goes into the lungs. That can be life-threatening. And someone asked me in the chat, not in the chat, excuse me, in the questions before, if my legs are swollen, is that okay? Is that a function of IBM? And the answer is you need to get that looked at, right? Because there is an increased risk of these clots in the legs, which can go to the lungs, which is life-threatening in myositis. Is there data in IBM? Not right now. There's work to be done. You guys are inspiring me. But here's the data. And again, this is not small data. It may be relative to the pulmonary fibrosis data, which is a larger population. This is 443 cases, and this is PM and DM again, but 443 cases of PM and 355 cases with DM compared to age matched and sex matched controls, right? And what you're showing here, the top panel, is the cumulative incidence for PM in red versus non-PM. So polymyositis patients in red versus non-polymyositis patients. And look at that incidence of VTE, which is clots either in the legs or in the lungs, right? Much higher. Same thing with DM, red, much higher. So that's well known. It's also well known that it tends to happen early in the disease. So this is the time since diagnosis. We've got PM, we've got DM, and it's increased. This ratio, if it's 1, it's even, right? But if it's greater than 1, there's higher risk. So you can see 25, 15, 14, 12, 9, 8. This is higher risk of these VTEs, okay? An important point. And whoever's got the swollen legs, can it be myositis? Can you get some swelling? Can it be venous insufficiency, where the veins are just not functioning well, so you accumulate fluid in the legs, and then typically you go to bed and it's better in the morning? Absolutely. But you have to think about this as well to rule out the worst. That's the way OCD doctors think, right? Rule out the worst thing. Don't, say everything's okay. Rule out the worst thing. That's our job. Okay, cardiovascular risk assessment. Everybody needs to be screened for cardiovascular risk. I'm going to show you a paper and 50 patients with IBM. It's going to say you don't need to worry about it if you have IBM. I don't buy it. Everybody in this day and age needs to have a good clinical history, family history of CVD, hypertension, hypercholesterolemia, diabetes, smoking. There are formulas that calculate, AHA, American Heart Association, formulas which calculate your 10-year risk of having a cardiovascular event, right? All of these factors go into it. Do you have diabetes? What's your systolic blood pressure? What's your cholesterol level, right? So if nobody looks at this, again, whether you have myositis or not, you're not going to get a risk assessment. And that's important because in this day and age, if you look at cardiovascular mortality from 50 years ago, the graph goes like this, meaning it's going down for the general population. And that is because risk can be assessed and medications can be used to mitigate that risk. And we're going to talk about statins. Very interesting. So clinical history, get your yearly testing. EKG, echocardiogram, everybody should have this, right? If you have myositis, every myositis patient who I meet is going to have an echocardiogram to assess their baseline cardiac function. No brainer. And then additional testing depends on that initial testing, whether you need an event monitor, a Zio patch to look for arrhythmias, right? Stress testing, MRI, et cetera. And we'll get into that with the IBM data. So management of disease, I alluded to this. This is a new day from 50 years ago when we couldn't do anything about heart disease. We can manage it. We can prevent events from happening, right? Only if it's assessed. For DM and PM, there is growing data that you need to treat the disease, right? If the young man who I mentioned earlier had very aggressive disease management earlier, would he have had a heart transplant? Can't look back and say, but he had a better chance, right? But controlling modifiable cardiovascular risk factors, again, key. So this is kind of a schema that we published, really just what I went over, starting with full clinical history. If it's abnormal, you go on to see a cardiologist, further testing, including stress testing. I found that primary doctors are very variable. I have some who are in it, who are ordering these tests themselves. I have others who are just more comfortable referring to a cardiologist. Second panel here, blood pressure, glucose, lipids, right? You got to get those checked every year. You can do them non-fasting. I hate making people fast. It makes me cranky, right? You can get a quantitative LDL, so you know what your bad cholesterol is without ever fasting. If you have triglycerides that are high, that's when you have to fast. So as long as they order the test correctly, you can get your LDL, you can get your HDL. And if your triglycerides aren't really a problem, you can do it all non-fasting, right? If you have high triglycerides, that's the one test that has to be done fasting. And then echo and EKG, right? That's something that, again, everyone should have as a baseline in my clinic with myositis. How else am I going to know is there any muscle involvement, right? How else am I going to pick this up? Okay, let's get in. We're into second part. What is there out there about IBM specifically? Okay, several questions from you. I'm going to read them off here, and then we're going to get into some of the data that's going to address them. Percentage of death due to heart and IBM. Great question. Is it more likely to have heart disease with IBM? Great question. I was diagnosed with a left bundle branch block. Is it a result of my IBM, or is it an independent problem? What percentage of women affected by IBM get heart disease? How does cardiac disease affect people with IBM? And where can I find information? So I'm going to show you the information. We'll get into these with some data right now. Unfortunately, for most, I don't have a specific answer, but I have some data, right? For instance, with the left bundle branch block, is it a result of my IBM or is it an independent problem? Don't know, right? I don't know that anybody is going to ever say for sure without being able to say, is there a scar there from some prior damage? Is there some fatty replacement? Again, but the most important thing is to be assessed, right? If there are arrhythmias that are occurring, to have the Zio patch to make sure they're not dangerous arrhythmias, right? Okay, so this is
So let me, Christina, I'm just going to interrupt for one quick second, going back to the questions. I see all the questions, and I just wanted to remind everyone who's on here, please, if there are additional questions or you have a question about what we're talking about, because I know we have a lot of information, please put it in the chat.
And I have
So,
more panels of questions, Nancy. So I got a couple other slides with more questions.
okay,
So
that's
I did
great.
all of them.
So I just wanted to make that reminder very quickly. I didn't mean to interrupt.
No, I love the interruption. I like
I love it. Okay, thank
listen
you.
to myself. Okay, so this is a study. It's an older study, 2010. But this is one of the initial studies that looked at the heart in IBM. 51 patients. They looked at patients cross-sectionally, which means at one time point, right? They didn't follow them over time, which is a very important part of any study if you can do it. They got several blood tests, initially a CK, a CKMB. I have little notes here. A CKMB is found in cardiac muscle. And so in past times, and it's important for your knowledge, just if you get, oh, your CKMB is abnormal, that's a cardiac test, my heart is abnormal. Well, maybe not, because it's also in skeletal muscle. So in someone with myositis, a CKMB can be in cardiac muscle, it can be abnormal without any heart involvement, right? And so in the general population, they use CKMB for heart disease detection, right? Not if you have myositis, but we'll get to the right test. Cardiac troponin T is the same thing. It's not specific for cardiac disease because it also can be expressed in regenerating skeletal muscle fibers. The one you need, and this is an old study, troponin I, right, is the cardiac specific. That is not expressed by skeletal muscle fibers, right? So in this study, they did all of them. They also did an ECG or an EKG and an echocardiogram. And mean age there, 67 years. 34 out of the 51 were men. Mean disease duration, 11 years. The majority of them had no history of cardiovascular disease or symptoms. There were some, 24%, who had some chest pain, some dyspnea, some palpitations. There were 14% who had a cardiac murmur. So this is the profile, the cardiovascular profile of what they did, looking at hypertension, hypercholesterolemia, diabetes, cigarette smoking, et cetera, et cetera. And you can see there is cardiac history here. We'll get to the conclusion of what the authors concluded from this, but 16% of the patients, it's a small number, 51, had a previous myocardial infarction, right? 16%, okay? So it's not insignificant. There is some history here. So the ECG finding, 24%, so a quarter of them had abnormalities. 3 patients had atrial fibrillation. 7 had a previous MI, as I just alluded to. And then 4 patients, which is 8% of this cohort, had signs corresponding to myocardial ischemia. So angina that they thought was related to blockages in the arteries. And then LV hypertrophy is the ventricle of the heart is a little bit thick. You can think of it that way. The echo data, again, 24%. So a quarter of the patients, small numbers here, but it's a quarter, had abnormalities on their echo. And they did not do advanced imaging studies, meaning MRI. We'll get to a paper on that. They had 8% who had an ejection fraction less than 50%. So again, you want around 60% for normal heart function. Less than 50 is some form of heart failure. And then most of them, I'm just going to skip down here to the valve function. You hear a lot of a little regurgitation from your tricuspid, your aortic, your mitral valve. They looked at that as well. And they didn't find a lot of significant valvular dysfunction. Only 1 patient had moderate tricuspid regurgitation. Okay, what about the laboratory data? Well, as I alluded to, the CKMB present in elevated levels, 82% of people, right? 78% had an elevated troponin T, again, without any cardiac pathology. So that's most likely coming from those regenerating skeletal muscle fibers. 1 patient who had severe cardiomyopathy had that elevated troponin I, which is the specific one, right? So the CKMB, the troponin T, those are common if you have myositis, in contrast to the troponin I, which is specific. So those, again, somebody tries to scare you with those, don't listen to them. It's troponin I that you want. What did they conclude from this? And I have to say, I didn't entirely agree. I do think this is a wonderful group and that they went and they looked at this, right? Nobody had looked at this. So I give them a lot of props in looking at this. What they did was they compared this data in 51 patients to large epidemiologic studies. And they said, you know what, the abnormalities we see here in ECG, EKG, echo, they're about the same as what we see in these large studies in patients, who don't have myositis, general population, right? And so they concluded that there's not evidence for cardiac involvement in IBM. And so we don't recommend routine comprehensive cardiac evaluation in IBM patients without cardiac symptoms. And again, they go into the troponin I, which I think is very valid, is the most informative and recommended biomarker. Perfect. I think this is based on their data in 51 patients. It's valid on their data. I think we need bigger studies. As I was showing you with the other IAM studies, we just need bigger numbers. If you do clinical research, your study is only as good as who is enrolled in it, right? So I think it's reassuring to say that there's not a huge increase in heart disease in IBM per this data, but I don't think we can be kind of content that the heart can't be involved and that there isn't some atherosclerotic risk just based on the numbers. And that's my interpretation for what it's worth. Okay, so troponin I, what would be a lovely study, oh, somebody's in the waiting room. Oh, okay, good, is to look at troponin I, right? And in blood specimens, right, from a large number of patients. Well, this is exactly what they did in 142 myositis patients. The only problem, and they found that they were increased, right? The sensitive marker of the heart. Only problem is, you can see here in table 1, it's DM-PM, antisynthetase syndrome, and immune-mediated necrotizing myopathy. So we don't have IBM. And this is an easy one that needs to be done in large numbers of patients with IBM to see if there are abnormalities. Okay, this was a case report. It's interesting. Again, it's an older study. It was a case report of an IBM patient, and I had some issues with it. It's a 36-year-old man who had been in a wheelchair since his mid-20s, which is very atypical for IBM. I presented because they did do an MRI of the heart. They did find abnormalities. They said he had IBM based on muscle biopsy. Okay. The point of the paper was to show that, and it's highlighted here in the bold, was that they did imaging and they could see in his skeletal muscle of his trunk a lot of fatty replacement. So that was consistent with having the disease for a long time, where the muscle is damaged and you can get fatty replacement of muscle. And then they also found that fatty replacement in the heart muscle, in the LV, which is left ventricle myocardium, right? And they kind of cited some papers from patients with muscular dystrophies saying that, hi, this is the first paper to report this in IBM. It's also known that the heart can be involved in other myopathies like muscular dystrophies, right? And they talk here about the amount of lipid, and we're going to get into the statin bit, the amount of lipid that was in the muscle on the MRI of the heart. So this paper, kind of as a follow-up to that, 10 years later, 2020, so fairly recent, this paper took 20 patients with IBM, and they did cardiac MRI as well. So MRI, we hear about on the shoulders. You can MRI the heart, gives you just a much better picture of the muscle, any damage, any inflammation, any replacement by fatty tissue, right? So these investigators took 20 patients with IBM and they matched them with control patients, right? And they looked at the cardiac MRI findings in comparison. So these are the IBM patients, 20 patients with IBM and 20 controls. The age was similar, 61 and 68. Female ratio you see here, 35 and 35%. They need a little bit more women in these studies. The thing that was different, and again, their interpretation I don't entirely agree with, but sometimes I will tell you, reviewers, no matter what you write, reviewers who are reviewing your article for publication will have feelings, and they'll say, I want you to put this in, right? So you're not always able to say exactly what you want to say because the reviewer has something, and that's this part of the scientific review process, and that's important. So arterial hypertension was different, meaning more of the IBM patients had hypertension than the controls. And again, that's getting back to what I talked about, cardiovascular risk factors. That assessment is important. And you can see here, there's more hypertension in the IBM patient than in the controls. This is the cardiac MRI findings. You have a lot of different indices here that they look at, and they looked at it in the IBM patients, and they looked at it in the controls. And here is the p-value, and anything dark here is a significant p-value, which means these two groups are different, right? So in all of these parameters of MRI evaluation, and we're not going to go through them, we don't have the time, but this is left ventricular stroke volume. They look at, is there a difference between the IBM and the control? And you can see here, there are several differences when they looked at the entire group, IBM versus control, the cardiac MRI findings. Now, what they conclude, and this again, where, it undergoes scientific review, it was interesting. They concluded that the cardiac MRI, that CMR, revealed subtle changes in cardiac geometry and tissue characterization in IBM patients when compared to the gender and age matched control group. So they found there were changes. They found further that there were higher extent of diffuse myocardial fibrosis, right, which is that damage we talked about, the scar, as well as a smaller left ventricular stroke volume, right? And then they concluded they may be due to the higher prevalence of arterial hypertension, right? So they're kind of saying there are abnormalities there. We don't know why. And maybe it's because there's more hypertension, right? So again, not conclusive, but definitely there are some changes there. And they can't tell you if it's the IBM because their control group was different and had less hypertension. We're getting to the last study here, and then we'll have a few more minutes for questions. One of the questions was the heart disease and the incidence of heart disease. And this was, again, small study, 64 patients in the Netherlands, but they did a very nice longitudinal follow-up over time in their IBM patients. And they looked at what was the cause of death. You know, what do we have to worry about in these patients in their cohort? So certainly they report the decline in muscle strength, and we need to do better. And we've talked about some research and starting this this discussion today, and we need more. But what they found overall at the end was the life expectancy was normal in their IBM patients compared to patients who didn't have IBM. What were the causes of death? And this gets to what's the incidence of cardiovascular disease. Well, one of the issues here, and this is the percent of the patients, is other uncertain is 17%, right? So about a fifth, they don't know what the cause of death was. Myocardial infarction, 4.3%. So not very high. That's somewhat reassuring. Again, the setting of 60-some patients and 17.4% uncertain. The diseases of the respiratory system, pneumonia, was the leading cause of death in this study. Okay, so more questions. Should people with IBM take statins? If no, what should they take instead? What is the role that the statin drugs play with IBM in cardiac tissue? And are statins associated with IBM? There is some very interesting research that has been done for a lipid geek like myself in IBM, okay? They've actually looked at muscle from IBM patients and found that there's increased expression of the bad cholesterol, the LDL, near these inclusions, right? As well as different LDL, VLDL receptors in patients with IBM. This was human data. And again, that led to further data. This was a rabbit study where what they did is they actually fed cholesterol to these rabbits, and they looked at their muscle, and they found that this feeding of cholesterol actually generated a pattern in the muscle that looked like IBM, right? So cholesterol, you know, was felt to really have potentially a pathogenic role in the IBM itself. That led to a study with simvastatin, which is one of the statins, looking at it in IBM. And they actually did this not to test whether it was safe, which is what most of us think about, right? They wanted to also see if it had any efficacy, right? So safety and tolerability, but they also looked for efficacy. 40 milligrams of simvastatin over 12 months. And the punchline is, I think what everybody's worried about is that the treatment appeared safe and well tolerated. None of them got better. So they can't, their conclusion was it cannot recommend simvastatin as a treatment for IBM, which is, again, against the grain. And most of us are thinking, is it safe? Is it causing IBM? No, they actually had data with these studies I showed you that it could help the IBM. So they wanted to do a further larger study. I haven't seen that yet. Okay, so a couple other questions. We're coming down to the end. I think I have this one and another set of questions that we'll get into. Any foods that are better than others for IBM? Answers, we don't know. I work with a lovely woman who's Dr. Guma from San Diego. She is, you know, looking at the Mediterranean diet, which we all know is anti-inflammatory. And I took this off the Arthritis Foundation website, and she's modifying it. She's looking at in rheumatoid arthritis, and it seems that maybe that stopping of the inflammation helps people with RA. Certain people who have high disease activity. We don't have data in IBM. Our group looked at the gut microbiome in patients with dermatomyositis, and we're expanding that study to look at other groups with different forms of IBM, as well as PM. And what we're finding, at least so far in the DM patients in that data set, was that the microbiome, you know, the bacteria that live in your gut and are affected by what you eat, are different. And the reason to look at the microbiome is because those microbes can affect your immune response. They can affect inflammation, right? And you can alter them with diet. A lot of unanswered questions here, but this is where we are. Okay, other questions. I would love to know what I can do to slow progression of IBM. I think that is
And
such.
Christina, we're okay on time, so
Oh, okay,
don't.
so I can stop my rapid pace.
Right, we're fine on
You guys
time.
know, and I don't even drink coffee, right? I'm a total decaf. But here we are. This is me. Okay, so what I can do to slow progression of IBM. You know, we talked like earlier when Nancy and others we were talking about the trials that are out there. I don't have the answer to this question. I wish I did. I think all of my patients are well ingrained with my exercise as much as you can with a physical therapist who's very, very, very sharp and very attentive to needs and what you can do and what you can't do. Question about heart disease. How important is this? If your father had heart disease, you know, that's a risk factor. And just getting back to the initial discussion of managing risk, you can't change your father, but you can look at the other risk profile and decide if medications are warranted. So one of the things that is remarkable and how cardiovascular guidelines have changed over time is it used to be we looked at bad cholesterol, the LDL cholesterol level, right? And if it was greater than 160, we would use a statin, for instance. Then it went to 130, then it went to 100, then it went to 70. We're targeting lower and lower levels, right? Based on the data in the large general population. Now, if you have diabetes, you should be on a statin regardless of what your cholesterol is. So father having heart disease, it goes into a risk profile and the greater risk needs to be assessed. Does IBM have any relation to cardiomyopathy? I had this 25 years ago after my daughter was born. So I don't know if that's a postpartum cardiomyopathy, which we do see. You know, certainly IBM, as I showed you some data with the MRI data, I think there's data there that suggests there could be an involvement of the IBM in the heart based on what they presented. Was it related to the hypertension? I don't think you can decipher that out. Autoimmunity, we know there's a predisposition in the genes, right? And you know, whether that predisposed to a postpartum cardiomyopathy, I don't know. I will say, and we'll get to it in the last bullet here. How do I get enough cardio when I'm unable to physically move to get my heart rate up? It's a great question. It's a great question. I know there are upper extremity classes. It is part of the cardiovascular risk assessment and prevention, meaning the activity. It is not the entire thing, right? So it is a component of it, but it's not everything. Is swelling in the legs? That gets back to my clot talk, right? With the veins, is it common with IBM or should consult with a cardiologist? Cardiologist, primary care doctor, right? Take a look at those legs. If you haven't had a duplex, which is just an ultrasound of the legs to look for a clot, get that done. Prevention, breathing issues. I think we talked about cardiovascular prevention and assessment. The breathing issues, that's a very important point. Breathing issues need to be assessed, right? You can get pulmonary function tests. Chest x-ray is where most people start. I will tell you, everybody with myositis in my clinic gets an HRCT of the chest, right? Meaning a high resolution CT so that it can look at the lung. And again, that's an area that I think needs to be looked at further in IBM in terms of interstitial lung disease. And I know there's some work ongoing in that. Does systemic inflammation, again, you must have been reading my slides before I even present them. Does inflammation caused by myositis contribute to accelerated vascular disease? We have data, yes, in DM and PM, not data that we have yet in IBM. You guys are inspiring. We have to look at this. And what organs does IBM affect? I put a little quote here from a paper, which was interesting because I think they're doing more research. I don't think that question is fully answered yet. What I put the quote in here for is there's an association with autoimmune diseases, meaning other autoimmune diseases, lupus. And I certainly have IBM patients who also have lupus, right? And then everything goes out the window of just assessing IBM, because then you have another component you have to think about. 15% of cases in this report, right? They say here there is no increased risk of myocarditis, interstitial lung disease, or malignancy. I think at least when I tried to find ILD data, the lung disease data, I couldn't find it. So again, takeaway is interpret everything with a grain of salt. More work needs to be done. All right, that's where I'll end.
Okay, so we have a couple of questions. Did I interrupt or do you have more, Christina, on
I'm
that?
done. I'm done. So next slide is this one.
Okay, well, we have a few more questions.
Okay.
So, let me just start with Reggie, who asked about volunteering for food study with polymyositis. And Reggie, I'm going to refer you to the Myositis Association because they're the ones that will be able to help you with that going forward. So, Christina, let's talk about for people who have or are unable to tolerate statins um, with heart disease. Is there anything that you can recommend for that?
Yeah, so here's a list. You guys can see this slide. I had a little sample question if we didn't have questions, but uh, is there any other treatment besides a statin, right? Here it is. This is a common one I get. And so here's the answer. Yes, right? And there are many other treatments if you can't tolerate a statin. And about 1 in 10 people doesn't tolerate a statin, right? And so just because you have myositis doesn't mean you're unusual, right? Because 10% of people, whether they have myositis or not, don't tolerate statins. So whether it's bile acid sequestrin, Zetia, PCSK9 inhibitors, many of my patients are taking these drugs, and there are new drugs coming out. Next, Letol, which I have a problem pronouncing. I mean, they are working on cardiovascular disease, huge problem in this population, and there are many therapies in development. So statins are just one component, lots more. You talk to your cardiologist and they love this, right? They love, and sometimes they'll email me and say, is it okay to give a PCSK9 inhibitor? Because they're a little nervous because some of these other medicines can also have myopathic effects, right? So there's some risk. So the cardiologist may be risk averse. I would say have them contact your rheumatologist or your neurologist, because my patients do really well who can't tolerate a statin with some of these other therapies, in particular PCSK9 inhibitors. And sometimes a different type of statin, right? Pravastatin at a low dose is tolerated a lot better than a torvastatin or rosuvastatin, right? So there's tinkering there to be done.
Okay, well, we're good on that. You have some other questions that are in your slides that you want to go into, or
I think I am, yeah, that was, this was a study we did a while back about statin use in patients with myositis. And this would just basically said that the majority of experts, this was the IMAX group, the international group, an old,
yes,
basically we use them, right? That's it. So I don't have
right.
anything else. I was ready
Well,
for the statin question, comes up all the time.
you did very, very well. Yeah, because we still have time left. But I'm gonna say thank you very much. And let me ask one quick question. There was so much information that you presented in that. And I just wondered, I know that a lot of us are going to be going back and maybe listening to the recording, but is there ever a dummied down kind of a short version of some of the things or short higher overview outline that
I
that
can
would
do
be available?
I can do a quick little page summary for you of the talk,
Perfect.
kind of like takeaway points.
Yes.
That's easy.
So and I'm saying that I'm going to try to come back and I'm gonna share my screen once more with oops, that's the wrong PowerPoint slide. Here we are. Does anyone else have any questions? Sharon, Laura, um, I mean, you're absolutely, you're fantastic. And I'm sorry that I couldn't make it to California last year
That's
to
okay.
see you.
California is, we're far away. It's a trek. It's a lot.
I know, and you're not going to be in Baltimore. So this year in Baltimore, we have over 400 people, which is going to be in about 2.5 weeks. And if you have not met, did you meet Paula? Did I ask you? I can bring our new executive director for the Myositis Association.
I want to say I have met Paula.
Okay. So
There
we just need to make certain that you are aware of Paula and Linda Colbert with them.
Yeah, no, I know
So
Linda, definitely. And before we
okay.
end, there were a couple here in the chat. If you answer the question regarding myositis, IBM, and PVC and medication conflict, I missed it. Time, please repeat. So the PVC, those, what I said about any kind of arrhythmia is it really, and there's a question about the bio patch. The Zio patch is what I mentioned about looking for any kind of dangerous arrhythmias, right? It's a patch that they can put on for a couple weeks to see if there are any arrhythmias. PVCs are common. They happen. They don't always mean there's an intrinsic problem with the heart. In terms of medication conflict, they're beautiful programs that any good physician can run and just enters in your medications and see if there are any kind of interactions there are predisposing things. There are specific medications that we know can cause prolongation of QT intervals and all this kind of stuff. But bottom line is check, right? Your physician should be able to check the medications. TDP-43 plays a role of cardiovascular disease. I don't know. This question from Jim. I'm going to have to look up TDP-43. I want to hear about that. Jim should tell me what this is. I haven't studied this. Does it help to take daily coenzyme Q10 and IBM to avoid statins? I don't know that coenzyme Q10 is going to do the job if you have an LDL cholesterol that's very high, right? I don't know if there are comparison studies. Statins are interesting. I'm showing you that CRP data where the inflammation level is related to cardiovascular event, that HSCRP. You have to take that into account because the statins are also anti-inflammatory. The coenzyme Q10, again, is what you really need to know is there a comparative study between those? Avoiding statins, I think it's a challenge, but each individual is different. So how coenzyme Q10 will affect you may be quite different. It may alter your whole profile from your CRP to your LDL. I wouldn't say yes to that. I don't know. How can we get neurology to take a greater interest in IBM and heart disease? Get another opinion. Like it can be a primary doctor who's interested in the heart and interested in IBM. You just need a caring physician who's thinking outside the box. And sometimes that's hard to find. But, I tell people, listen, if somebody wants to see a different physician, that's their right. And that's what they should do. Who cares about the physician? Their feelings are going to get hurt. It's not about them. It's about you. Find someone who listens. Find someone who does have an interest. Bring them something to look at. They'll get inspired from you, right? Is it required to take a nuclear stress test? If you can't, get on a treadmill, get your heart rate up, a lot of times they'll do a nuclear stress test, right? Because then they can get your heart rate up and see if there's any abnormalities there, which suggests you have some blockages in the artery. So again, required, it depends on your baseline risk. And if there are symptoms and things that they want to make sure you don't have any blockages in the arteries that are significant. That's why you do a nuclear stress test. And if there are, then that goes to the next step of unblocking those. And in rare cases, but they do happen, a surgery, like a bypass surgery, that saves lives, right? That's why the cardiovascular mortality is different. Okay, I've been intense to get my cholesterol down. And you heard of this. I haven't used berberine for this, so I don't know enough on it. You guys are going to make me read more and learn more. So I haven't had too much exposure to this, so I can't advise you. But I would look at it and listen to your cardiologist and look at the pros and cons and kind of make an informed decision. And if there's any kind of question, I always tell people, get another opinion, another cardiologist. There are a million of them, right? Make sure they're saying the same thing, right? That's another double check, someone who used this. And yes, I think they're going to have recorded the slides and the images and everything.
Yes, yes.
Yeah.
We are recording the slides and we appreciate you putting together a cheat sheet. And can you also put together a cheat sheet for some of the tests that you think are important to us as myositis patients?
Yeah.
That either we should ask our, whether it's a myositis person, whether it's our myositis physician or our regular internist to have done, because I think that's very important. And you brought up a couple of points, and unfortunately, you know, as I've been talking to so many numerous physicians and hospital administrators, it's being patients in today's society is very difficult
Yeah.
because, as you're saying, we have to keep going on and keep advocating for ourselves.
Yeah.
Since
Yeah, no, you do. And the physicians, you know, a lot of physicians are getting a little downhearted because they don't have the time they want to spend with their patients, right? It's not that they don't
absolutely.
want to. They are, you know, you have to see this many patients in a day. And again, the frequency sometimes of a visit is the better thing than the duration of one individual visit, right? When I have a sick patient, I may see them every week, every couple of weeks, just to keep going after the problem and get there. So that's something I often recommend. If you can't get enough time, then see them more frequently if they're the one.
So I am good. And Dr. Charles, you know, we're thrilled. We're just thrilled to have had you here. Laura and Sharon, do you have anything further to add to this? Laura's quiet. Sharon?
It just
No.
makes me question or add more information to my cardiologist to look into maybe some of these other things. He's actually very interested in the myositis aspect. And he's always asking me, well, where do I go for this information? And based on what you're saying, there's just nothing
There's
really
not a
out
lot.
there for us.
Yeah, I mean, I really, unless I'm missing some study that's in a stage of publication, you know, there is what there is. I think it's coming along. The MRI study was 2020, so and that's in the last 5 years, and that did show some differences. But there's not. I don't think he's missing a big source of information. I just think it hasn't been done. We need to do some more.
Yeah, it's fascinating what we're learning, and as we're going through it, and as patients, you know, every day there's more and more stuff that keeps coming to us from all of you, and we're certainly appreciative, as we were talking earlier about the cross-pollination, both domestically and internationally,
Yeah.
in what you're working on. I know that I'm going to forward, and I think I mentioned it to you, your information and this to a whole series of physicians in Florida that run a cardiovascular institute. So they're not myositis, but they run an institute. So with that, I mean we normally go a little longer, so we'll just keep on going unless, is there anything you would like to ask of us as patients?
Um,
I mean, just be a little different.
yeah. Elizabeth looks like she was raising her hand.
Yeah.
Okay.
Hello. My accent would be a lot different to yours. I'm from Ireland.
Oh, welcome from Ireland. It'll
Thank you. Thank you.
That's wonderful.
Well, a couple of things. Because I live in Ireland, would there be any possibility that I could, from this far away, offer to be on a volunteer list?
Oh yeah, I would love it. You guys are making me think about IBM and how I need to do a very broad, large study in cardiac disease. So hold tight, Elizabeth. I'm going to come back to your group and see about writing a protocol and trying to get some funding for it. And if I do, Ireland or not, we'll figure out something. International research is really something that is current and that we're doing. It just depends on you know, the specific protocol, but I have samples in my lab, blood samples from patients all over the world that were collected as part of a research program in a different disease. So anything's possible. Again,
Yeah,
no,
well, keep me in mind. And just two things, just from what I've read, it looks like because I've been diagnosed with the IBM disease, exercise seems to be the only treatment that we've been given.
Yep.
And
And
yeah,
Exactly it.
And Elizabeth, I'm gonna say thank you for joining us, and just stay with us, because we also know that there is a myositis association. I've met the people in England. There's a strong group in Germany, but we do have a lot of people from, and we also talk to all the Australians frequently, as Dr. Charles knows. So, so from our point of view, yeah, we're happy to help. And any questions you have for us from an IBM standpoint or other myositis standpoint, please let us know, because we're more than happy to be able to help.
That I would ask is, are any of I would imagine it's happening, but are your doctors asking you about cardiovascular risk and doing the assessment? That's, I think, I'm assuming it's not enough, but maybe it is.
I would, prior to being diagnosed, I would have been in a private hospital in Dublin, and the first thing that they did was loads and loads and loads of all sorts of cardiac tests. Actually, the cardiac unit took me on board first. It was only when they discovered I didn't seem to have any problem there that the neurologist then took me on board and was able to diagnose what my problem was.
Right. Yeah. No, so I think that that's important, and that was the reason I asked if you can put together a cheat sheet for cardiac questions that or simple preventative tests that we should have from our internal med doctor or some of our other physicians, whether we go to a neurologist or rheumatologist on a regular basis. That would be extremely helpful to us as we move forward. So no, this is absolutely fantastic. And for those who have asked, when is this going to be available? With some of the upcoming things with IBM, I would say keep checking the Myositis Association YouTube channel. And we will, and actually, their YouTube channel for the information on that. So, this will be posted on there. And with that, I'm going to say thank you again. I'd like to share a few things that are coming up with you. So for those of us that are new, we need to, again, it's not too late to register for the September 6th through 8th annual patient conference. But more importantly, on Saturday morning at 9 o'clock, you're going to see a program that is being from the women with IBM. And this is talking about, today we talked about heart, and this is talking about mental health and myositis, how our mindset affects our myositis journey. So we talked about the slowing of progression, and this started out to be how our mindset can really affect our myositis journey. Can it slow the progression? Can it not slow the progression? And we are honored to have 4 spectacular panel members talking about our mindset and mental health and positivity with it. Some of you know Megan McGowan, who is is an occupational therapist and is the behavioral health clinical supervisor at Johns Hopkins Bayview with the Myositis Center, with the Myositis Clinic. Also, Allison Fisher, who's been on here many, many times. We have Lisa Motley, who is an IBM patient, talking, and Dr. Eleni Tiniakou. Dr. Tiniakou, again, is a rheumatologist working in myositis research. So we're going to be able to talk about our mental health journey, staying positive and coping and creating that resiliency that we have through our myositis and IBM journey, and hopefully be able to cross-pollinate our mental and our physical health going forward. And for those of you who are coming to Baltimore, please, we hope to see you at 9 o'clock, because it's live and it's not going to be virtual. So that's September 6th through 8th, and there are some incredible presentations along with a spectacular keynote speaker and closing speaker. I can't say enough. October 15th program, we're talking about adaptive ADLs, devices, and but we're going to talk about it a little bit differently. We're going to do a networking session so we can do some small breakout groups and then go into our after we get our reports from our groups coming back. November 19th, again, we're going to have another networking session. This session is going to be based on dysphagia. A lot of us have dysphagia problems. So again, we're going to be breaking out into small groups talking about dysphagia. We're going to give you 5 or 6 things to talk about, or whatever your group talks about. But when we come back to talk about, give our group reports, we have a speech therapist, Breton Jenks, who I personally used along with the Johns Hopkins group. Breton has over 30 years experience working with neuromuscular patients and dysphagia, and she's going to be here so that any questions we have from the group, she's going to be able to help. I would love to have some thoughts on what people are looking for next year. One of the questions and one of the things that I think is important is getting back to research. I've asked a couple of physicians